This is Aging Forward, a podcast from Mayo Clinic about the science behind healthy aging and longevity. Each episode, we explore new ways to take care of our long-term health, the health of our loved ones, and our community, so we can all live longer and better. I'm Dr. Christina Chen, a geriatrician and internist at Mayo Clinic in Rochester, Minnesota, and this episode, we are talking about the prostate, what changes to expect as we age, the risks of prostate disease, and tips for prevention and care. Our guest today is Dr. Derek Lomas. Dr. Lomas has a pharmacy background but trained at Mayo Clinic and is now a practicing urologist at Mayo Clinic in Rochester, Minnesota. Dr. Lomas also has a book out called Mayo Clinic on Prostate Health. So thank you so much for joining us, Dr. Lomas. Great to have you here today.
Absolutely. It's my pleasure to be here.
All right, so let's start with the very, very basics here, which is talking about the prostate as an organ. What is it? What does it do? And how does it impact health as a whole?
So the prostate is a small little gland about the size of a walnut. It's only found in men, and it sits just below the bladder. It kind of sits like a donut underneath it. The bladder, the urinary bladder, holds urine, and it produces some of the fluid in semen, the ejaculate, and helps sperm travel. So it's important for reproduction. But since the urine has to flow through it, it can affect your well-being as you age. As men get older, it's normal for the prostate to grow. And if that donut hole shrinks up, it can press on the urethra, leading to problems with urination, waking up at night, things like that.
Sounds like an important gland.
Yes.
But with all organs that change over time, the prostate also changes.
Yeah.
Can you describe a little bit about how aging affects the prostate gland?
So the more time you're alive, the more time the prostate has to grow. Every man's prostate grows at a different rate. Some men it grows rapidly. Some men, it grows very rarely at all. But if you ask most men in their 60s, 70s, 80s, they're starting to notice a difference with their urination.
So prostate growth is very common.
Mm-hmm.
What are some other common issues that surface with the prostate over time? And why is it such a key concern for aging men?
So probably three main things that go on with the prostate. We talked about growth called BPH or benign prostate hyperplasia. It just means kind of non-cancerous growth of the prostate. Again, very common with age. Another condition that men can suffer from related to the prostate is called prostatitis. This can be related to infection or just inflammatory response. This can cause discomfort, pain. And then prostate cancer is another one we worry about. This is one of the most common cancers in men and increases in risk as men age.
Are there normal changes with prostate growth in terms of just what's typical and what's atypical?
It's natural to have some urinary changes as you age, weaker flow, going more frequently. It all has to do with bother, though. If you're not bothered by it, if it's not impacting things you like to do, it might not be a big deal, but pay attention to it. If it's starting to impact your quality of life, keeping you from doing things you like to do because you're always worried about that bathroom, then it's probably time to see a doctor.
I think the most annoying symptom that I hear commonly is that need to get up in the middle of the night, having to wake up and then urinate, and then they can't fall asleep.
Waking up at night or nocturia is one of the most frustrating symptoms, and there's a lot of different causes. We'd like to say it's all the prostate, but there's so much that goes into it. So taking into account what you drink in the evening, what you drink in the last few hours you're awake is going to turn into urine at night. And if you overfill your bladder, it's going to send you a signal to wake up. Other things happen when you lay down as well. If you're someone that gets a lot of fluid that builds up in your legs and you lay flat, all of a sudden that's going to turn back into blood and back into urine and going to make you go up. And things that are completely unrelated to the prostate can cause waking up at night as well. Common thing I see is sleep apnea. So it's really important to kind of look at the whole picture rather than just go straight to the prostate. So a lot of men, once we manage their fluids, get them a sleep study, look at other things, raising their legs on up in a chair at night, we can really reduce that. But it's really kind of what we call multifactorial, multiple things that contribute.
Mm-hmm. And you mentioned earlier that when things become bothersome enough where it's affecting your quality of life, to seek evaluation then. Is there benefit to doing that earlier? Because I feel like by then it's fairly progressed.
So if you're starting to notice difficulty getting the urine out, feeling like you're not emptying at the end, certainly mention that to your doctor. There's non-invasive tests that can be done to check your bladder flow, to check how much you're leaving behind. Certainly not too early to consider workup, but maybe too early to consider things like surgery if it's kind of a mild degree of bother.
Yeah, at least to be informed about what to look for, right? Let's talk about risk factors in screening. Can you give us a general overview of the biggest contributors to prostate disease as a whole and cancer for that matter?
Age is the biggest factor.
Right.
It's going to increase with age, but family history matters a lot too. If your dad or brother, uncle had prostate cancer, your risk is higher. There are certain genes that can predispose you to the BRCA genes, breast, ovarian, pancreatic. If those all run in the family prostate, then you can be at higher risk if you carry that gene. African Americans are also at higher risk for prostate cancer, so really important for screening and even maybe to begin screening earlier. In terms of other risk factors, certain environmental exposures, pesticides, industrial chemicals, Agent Orange, things that have been associated with prostate cancer as well.
I see. And how about diet and lifestyle? Does that impact prostate health much?
It does. There's reasonable evidence to suggest that eating a heart-healthy diet, Mediterranean-type diet, fruits, vegetables, avoiding red meats can be healthy for the prostate. I was just at our largest urology conference of the year where they were presenting on men with low-grade prostate cancer and does diet and exercise prevent progression, and found that by having a Mediterranean or heart-healthy diet, they saw less progression. Unfortunately, exercise didn't, but there's many other reasons to exercise. And I tell patients, it's probably going to be a mild effect on your prostate health, but if blood's not pumping to your prostate doesn't matter. So,
True.
Heart comes first, and that's going to be doing the most for someone's health overall. So I never discourage it.
Or we can make the argument that exercise may have a role in pelvic floor health.
Absolutely. If we look at the other side, not the cancer side, we know if you're overweight, you have higher risks of urinary symptoms, urinary incontinence, things like that, and reducing weight can really improve that.
And as we talk about screening for prostate cancer, there's this big debate back and forth about, when to screen, how frequently that should occur. What's your take on all that?
In general, for screening of prostate cancer, we use a blood test called PSA, or prostate-specific antigen. This is a substance that all prostate cells make. It's not specific to cancer, but cancer cells tend to be more poorly formed, so more releases into the bloodstream, so we can see higher levels. It's important to say off the bat that PSA doesn't equal prostate cancer. Other things like inflammation, large prostates, even temporary things like exercise, sexual activity can cause temporary increases. But it's a really good screening test, and it's become kind of the mainstay of screening. Rectal exam, where a gloved finger is put in the bottom to palpate or feel the back of the prostate, is helpful as well, but we can only feel the backside, so a negative prostate exam isn't necessarily helpful. Helpful when we feel something. So really, that's become kind of lower down on the list. But in general, we do recommend screening. The American Urological Association does have a position on screening. We say that a man should get kind of a baseline test around age 45. If you're higher risk, family history, African American, you might want to consider it at age 40. And then using that number to kind of risk adjust how often you need to get it afterwards. But in general, we say every 2 to 4 years. Now, if a man's at higher risk, maybe you do that yearly. If their first PSA is really low, maybe you're on the 4-year spectrum. The benefit of doing it less frequently is, on the flip side of not missing a diagnosis, we don't want to overdiagnose prostate cancer. So you may avoid that by doing a less frequent test, but still picking up the cancers that matter.
That's helpful to know. How about in the oldest old, say 80 and above?
So our guidelines say up till about age 70. It's probably a good idea in most patients, but it still is life expectancy dependent. So in order to get a benefit from a diagnosis of prostate cancer, you really need a life expectancy of about 10 years, because if you have a less than 10-year life expectancy and we find a cancer and we treat it, well, it probably wasn't going to be the thing that got you anyway. And now we've needlessly diagnosed and treated and maybe caused harm. So after 70, it's much more of an individualized discussion of, well, what else do we have going on? We can use actuarial tables or calculators to tell us, well, an average, 74-year-old, how much do we think you have left? And then you can pull in other conditions they have and see where this is on the list. And if life expectancy is less than 10 years, then it's probably a good idea to stop PSA screening.
And then that in combination with, you mentioned earlier, the digital rectal exam for someone who's never had it before. Can you describe what that's like?
So what it involves is the doctor or provider will put a gloved finger in the bottom, lubricated, and press on the back of the prostate to feel for any lumps. It feels pressure. It may be uncomfortable. Generally, the man lays on his side or leans over the exam table. And again, this is now becoming considered optional as part of the screening, just because the ability of the rectal exam alone to detect cancer is probably pretty low overall.
Okay.
So if that's what's keeping you from getting screened, you can still get PSA screening and decline the rectal exam, or if you're doing remote screening or something like that.
And then there's other things too, like the urine specimen and the symptom score index. There's ultrasounds and then biopsies, each one becoming more and more invasive in nature. So which ones do we need to know about early on? And does everyone need to go through all of that testing?
First off, if you have a PSA test and it's elevated or a high level, the first thing you should do is get it repeated. We'll usually repeat it in 4 to 6 weeks because, as we talked about a little earlier, there's things that can temporarily increase the PSA levels. If you're worried that there might be a urinary infection contributing, maybe the person's having some urinary urgency, burning, things like that, then a urinalysis or urine culture can be helpful to kind of rule that out. If that second repeat test is still elevated, then there's a couple different pathways you can take. The kind of historical pathway was you'd go straight to a prostate biopsy. That would involve usually 12 random samples taken throughout the prostate to see if we could find prostate cancer. More recently, there's been a shift to using other testing before jumping right to biopsy. That can be additional urine or blood tests, so what we call biomarkers. So in the urine, we can look for things called exosomes and find a probability of cancer being present. There's blood tests that look for not PSA, but things like PSA, again, to try and predict the likelihood of a cancer being present. But by far, what we use most commonly is imaging and prostate MRI. Prostate MRI is really good at ruling out prostate cancer. So if there's no cancer present, you'll get a low score on an MRI. It has a 5-point scale. And if the MRI is negative, and maybe it gives another explanation, like the prostate's on the larger side, and that explains the PSA, there's usually a less than 10% chance of a clinically significant or aggressive cancer being there, and we can avoid the biopsy altogether.
I see.
If it's a higher score, it allows us to direct the biopsy or aim at where the tumor might be in the prostate. So that's kind of the pathway we generally take here. If there's a elevated PSA, confirmatory PSA, we go to MRI because it's going to give us a much bigger picture of what's going on and potentially avoid a biopsy altogether. There's also calculators we can use that take into risk factors, family history to, again, figure out a probability. And then on the urinary symptom side of things, we can do symptom scores to assess the degree of bother and tests that look at bladder flow and things as well.
Sounds like a lot to kind of choose from and juggle from.
Yeah, there's a lot out there, and it's not one size fits all. There's certain situations where maybe a man can't get an MRI because they have maybe an implanted device, and we have to kind of alter our pathway. So, we have different avenues available. There's not necessarily a right answer, but we'll find the right one for that patient.
Coverage varies by plan. View contracts and exclusions at endurancewarranty.com.
This is an announcement to all United States vehicle owners who own a 2003 or newer vehicle with a manufacturer's warranty about to expire or no warranty coverage at all. With the struggling economy and the cost of living on the rise, Endurance is now offering an affordable low-cost vehicle coverage plan to the general public. As of today, you could be one of millions of drivers that now may qualify to have your vehicle protected under this coverage and have all future covered auto repairs paid directly to the repair shop for you. You pick your plan, you pick your deductible, you even pick the repair shop. Roadside service, towing, and rental coverage is included. To all United States vehicle owners who own a 2003 or newer vehicle with a manufacturer's warranty about to expire, get your vehicle protected now and save your wallet from costly vehicle repairs. For your free 5-minute quote and to see if you qualify, visit EnduranceWarranty.com. EnduranceWarranty.com.
So let's dive a little bit deeper into specific prostate conditions. You mentioned 3 of the most common ones, and we're going to focus on BPH and prostate cancer today. Let's start with BPH, which is benign prostatic hyperplasia, a non-cancerous growth of the prostate. Does it need to be treated?
So it doesn't always need to be treated. And sometimes we'll get imaging back and we'll make a comment, prostomegaly, which means a big prostate. And if you ask the patient, oh, how's urination? Oh, no big deal, no bother. Just having a big prostate doesn't mean you need medication or need treatment. A lot of times we'll have patients fill out what's called an IPSS or International Symptom Score for their prostate, and it'll put patients into categories mild, moderate, or severe in terms of their symptoms. It asks about things like urgency, frequency, emptying, and we can use that to help guide, how aggressive we need to be with therapy. But if they're in the mild category, we'll review the options, whether it's taking medications or surgeries, and they might feel at that point the risks outweigh the benefits of the side effects of surgery and medications and elect to monitor. We call that monitoring or watchful waiting. But if they're starting to have more of an impact on their quality of life, or they're having negative consequences like urinary tract infections, maybe they're not emptying their bladder completely, maybe they ended up in the ER because they couldn't pee and required a catheter, they're having blood in the urine, they're having other issues, then it's time to think about medications or maybe even surgery.
Does every BPH situation progress? Like when you start to develop symptoms, it's like, okay, we can watchfully wait. But if you treat them early, is there a role in preventing it from getting to the degree of...
So the one thing we have to be careful about is the bladder function declining with time.
Sure.
And the most common medications we use for BPH are called alpha blockers. These are medications like Flomax or Tamsulosin, Rapaflo are some of the trade names. And these work by relaxing the muscles within the prostate and bladder neck and allow the urine to flow out better. They work very well, but they're, I don't want to say a Band-Aid, but it's a temporary. They work while you take them. So sometimes it's hard for men to realize that there's changes happening under the surface. So it's important that if you start on medications that you're continuing to monitor the situation, or if you're doing watchful waiting, that you're having ongoing follow-up to look at things like, are you starting to retain more in your bladder, or your symptom scores going up? Because we don't want to miss our window. If we have the bladder under stress for a long time and we don't address the root cause, then by the time we go in and do the surgery, we may have missed our optimal strategies. There is, I think, a role for early surgery in men that are having severe symptoms, or maybe men that don't want to take medications or don't tolerate medications. And then we have the advantage of being able to do maybe some of the more minimally invasive surgeries that maybe carry lower risks or have a quicker recovery, as opposed to if we intervene late and we have to be very aggressive with removing a lot of tissue.
What's the most common surgery you do for BPH?
So the most common surgery I'm doing right now is called aquablation. Aquablation, or robotic water jet ablation of the prostate, is kind of a newer one. We've started doing it last year, but it's been around for 5 or 6 years. We kind of waited for the data to mature before we decided to bring it on here at Mayo. Essentially, what it involves is a procedure under general anesthesia. We put an ultrasound in the patient's bottom that allows us to visualize the prostate on imaging. And then we put a special camera into the urethra, again, while the patient's asleep. And out of the side of that camera is a high pressure water jet. Think about like a pressure washer that aims down. And we're able to, on the ultrasound, draw the amount of tissue we want removed from the prostate. And then the robotic water jet follows our plan and basically pressure washes the tissue out of the prostate, or if you're mechanically inclined, kind of a CNC machine, and kind of removes that tissue. And it's using water jet, which is avoiding a lot of heat or thermal effect. As you can imagine, though, that doesn't do a lot to seal up blood vessels. So we do have to go in after that is done and kind of seal up any areas that are bleeding and trim the tissue away. Some advantages of this approach is, since it's imaging guided and robotically assisted, it's very consistent with the amount of tissue that's removed. It's also specifically designed to spare tissue in certain places. So some of the risks with prostate surgery and BPH surgery are changes to urinary and sexual function. So urinary leakage or incontinence on the sexual side, erectile dysfunction, and changes in ejaculation or loss of ejaculation. But with this procedure, there are very low rates of incontinence, low rates of erectile dysfunction, and it spares tissue in such a way to try and promote maintaining ejaculation as well. And it works over a wide range of prostate sizes, from the mild to moderate all the way up to the large prostates.
That is fascinating. I'm just envisioning like it's it's almost like a water pick for your teeth.
Yeah.
Except you're doing it in the prostate.
And patients either, most of them stay just one evening in the hospital and have a catheter for a couple of days after.
Okay.
After the catheter comes out, there's some irritation with urination, some intermittent mild blood in the urine. We ask them to take it easy for a couple of weeks, but in general, they're noticing pretty immediately improvement in flow. Those that were having catheters before have maybe gotten away from the catheters. So it's been an exciting thing to be able to offer and complement our other things, ranging from steam ablation of the prostate all the way up to robotic simple prostatectomy, where they're actually surgically removing the center of the prostate for very big prostates. So we got all things.
A lot to choose from. Yeah. Thanks for sharing that. I didn't realize how much innovation has expanded in that space of treatment. And then prostate cancer. This is probably a whole topic separate in itself, but just at a high level, can you just talk about the general stages? How are the symptoms different from BPH? And then how is each stage treated?
Early prostate cancer often has no symptoms, and that's why we need to use screening to find it. Most men that come in with symptoms, it's not prostate cancer causing, it's the BPH. And the prostate has a couple different zones, but in general, there's an outer shell called the peripheral zone, which is kind of a shell around the outside, and a center portion called the transition zone. The transition zone is where this BPH growth is that pinches on the urethra. Cancer generally doesn't form there. It generally forms on the outer edge. So it takes kind of more advanced cancer to start causing symptoms, but they can be the same: difficulty urinating, weak slow stream, blood in the urine. If it's really advanced or spread, it could be muscle aches or bone pains, but generally though, it's no symptoms. So that's why screening is important. In terms of stages, most cancers are found when they're localized, meaning in the prostate alone. But with time, they can grow outside the prostate to things nearby, like the rectum or the bladder, and then metastatic, or if it's spread beyond the prostate, to things like lymph nodes or bones. Again, fortunately, these days, we find most of them when they're localized, and outcomes are very good.
And as far as treatments, have we seen overall better outcomes over the years? Now that we've done more research and we know more about it, and the treatments have kind of advanced as well. Is survival better compared to, say, 20, 30 years ago?
So survival is really good, especially for localized. So another thing we use for prostate cancer is something called risk stratification. And so cancers broadly are low risk, intermediate risk, or high risk. For low risk cancers, many times we're telling patients it's appropriate to monitor it or do something called active surveillance, because these cancers are unlikely to grow or progress, and we can avoid the side effects of treatment. So we kind of assess the likelihood of the cancer causing them harm. Active surveillance doesn't mean we forget about it. We follow PSA testing, imaging, even follow-up biopsy. And if the numbers change, if it moves to a higher risk category, then we intervene at that time. The good news is, whether we intervene at day one when they're diagnosed or a couple of years later, if they progress, the outcomes seem to be very similar. It's about kind of delaying treatment until it's necessary, hopefully forever in some men, but in other men, at least they're getting several years of avoiding side effects. In terms of surgery and radiation, so the most common surgery is what we call radical prostatectomy. Historically, it was an incision, a cut in the belly, open the patient up, remove the prostate. Now it's being done minimally invasively with robotic assistance in most men. We even here at Mayo have a single port system where they can do it all through one kind of small incision mainly. And then, my colleagues that do prostatectomies have advanced techniques that are important for improving continence or urinary control. And so, there's been a lot of advances there. And same on the radiation side, between more focused radiation, proton beam radiation, putting special gels behind the prostate to give more space from the rectum to help reduce the risk of injury to the rectum. So again, if men are worried because they heard their father or grandfather had a terrible time with prostate cancer treatment, and that's keeping them from getting screened, it has come a long way.
Thank you for that reassurance, because I think we hear of the bad case scenario. We don't realize that there's many people do well.
Yeah,
and you mentioned
absolutely.
some side effects in terms of incontinence, sexual dysfunction, but do people generally do pretty well after treatment?
In general, there is going to be a recovery. So certainly in the short term, those are common things. With more recovery, things like pelvic floor exercises to strengthen muscles. It's uncommon in my experience to see men in diapers, which is what every man worries about when they hear prostate surgery. But there are cases of severe incontinence or leakage, but we do have options. We have artificial sphincter devices that can be put in, urinary slings, medications, and same on the erection side. Many men can respond to oral medications like sildenafil, Viagra, tadalafil, Cialis, but there's things like vacuum erection devices, medications that can be ejected into the penis, and even implants. So there's ways to treat these things if they do arise.
Are there any other cool advancements in the space of prostate health, whether it's cancer treatment or BPH or?
Lots of new advancements. So from a cancer standpoint, using kind of an image-guided approach to diagnosis rather than just jumping to biopsy with everyone. So that's letting us have better biopsies, but also avoiding overdiagnosis. Because as I mentioned, a lot of these low-grade cancers, we're going to tell you to watch it. So really, we're not getting a huge benefit by finding it. So how can we do a better job of finding the men that are going to benefit from a treatment, but not giving that undue worry to men that have a cancer that's not going to threaten them?
Makes sense.
The other advance is the way we do the biopsy. So the classic approach to a prostate biopsy was to put an ultrasound in the rectum in the bottom. Through the ultrasound, a needle would pass. It would go through the rectal wall and into the prostate. It's called a transrectal biopsy. As you can imagine, maybe not the cleanest way to pass a needle.
Right.
And so it's associated with infection risk, something called sepsis was a severe infection. And there's even reports of patients unfortunately dying after that type of biopsy. So we switched our practice over to something called transperineal biopsy. Now for transperineal biopsy, we still put the ultrasound on the bottom, but the needle passes through the skin. The perineum is the patch of skin behind the scrotum. And so we can clean that off. And that really helps reduce the likelihood that you're passing through a contaminated field. We can de-escalate need for antibiotics. And I also feel it gets us kind of some better sampling around the prostate. So that's been an advance. Other cool things, artificial intelligence, AI is increasingly being used in all things medicine. On the prostate side of things, imaging, helping us review the MRIs, helping us review the pathology, predict outcomes. So that's been something interesting to see. And then on the cancer side, again, focal therapy, which is something I work with, and that's rather than pulling out the whole prostate, radiating the whole prostate, treating just the portion that has the cancer.
Can you expand on what focal therapy is? What does that look like?
Broadly, focal therapy is the idea that we're going to go in and ablate or use an energy to destroy a portion of the prostate that contains the cancer and try and leave the rest of the prostate alone. And we do this in a lot of other diseases, a lot of other cancers. In the kidney, we remove a part of the kidney or freeze a part of the kidney. For breast cancer, we do a lumpectomy. For brain cancer, we don't remove the whole brain. So prostate's one of the few organs or cancers where we just take out the whole organ. And there's a couple of reasons for that. Historically, number one is up until recently, we didn't have great imaging of the prostate. We couldn't really see it well on things like ultrasound and CT. As prostate MRI has gained popularity and we've become good at seeing it, we're better able to kind of direct therapy. The other part of it is a lot of prostate cancers are what we call multifocal, meaning there's not just one tumor in there. There may be more than one. But with MRI and biopsy, we're able to identify those patients that might have what we call an index lesion or dominant tumor that will be candidates for this.
So can you tell us more about the different technologies and procedures that you use for focal therapy? Because this seems like it's an evolving field, and there's just a lot of ways to treat the prostate using that method.
The first technology I use is called HIFU, high intensity focused ultrasound. And it's a procedure done under general anesthesia. It involves putting a special ultrasound probe in the bottom. And it's kind of like a magnifying glass in the sun. If you focus the sound wave just right, like you would with a magnifying glass in light, you can create heat. So if you focus your magnifying glass on a leaf, you can burn a hole in it. You pass your hand right in front of it, you don't feel it. So it's doing that with sound waves through the rectum. And we can direct that at areas within the prostate to heat and destroy areas about the size of a grain of rice, but then we keep doing that in quadrant or section of the prostate to create an ablation. And we use a 3D model of the MRI that's imported to help us guide that as well.
I'm going to butcher this, but irreversible electroporation.
Yeah.
Did I say that right?
Yep, you did.
What is that?
Yeah. So that one works a little differently. It's again under anesthesia, ultrasound on the bottom, and we pass small needle-like probes through the skin, similar to how I do a transperineal biopsy. And those probes basically surround the tumor. And then an electrical current goes between each of the probes and passes through the tissue. And what that current does is it creates holes or nanopores in the cells, and those holes can't repair themselves, so the tissue dies off. So anything within the path of where we place the electrodes is able to be killed. Now, since we keep the current and power at a level lower, it doesn't create a lot of heat or thermal effects. So we think this might help have some sparing effects on things like nerves or the urethra that runs through the prostate. We just were part of a trial using this system, NanoKnife system, that should be coming out soon. But what we found was it had low rates of complications. And when we went and biopsied the patients a year later, most of the men were cancer-free. This actually led towards FDA approval for the technology just this last year for prostate ablation.
There's a lot of blasting and vaporizing and shooting and
Yeah. Now, it's important to say with these focal therapies, not everyone's going to qualify. The other thing is that this is newer. And if we look at our guidelines, both from urology and National Comprehensive Cancer Network, these aren't quite part of the standard of care yet. They're still considered investigational. And that can have some drawbacks for things like insurance coverage. And then follow-up's important. Since we are only treating a portion of the prostate, we got to continue to monitor the rest of it. So it's not for everyone, but I think it offers generally a quicker recovery, offers lower rates of sexual dysfunction, lower rates of urinary dysfunction, and I think is a good option for men that qualify.
What's your take on over-the-counter supplements? The supplement world is just so big, and there's all sorts of things out there for prostate health between saw palmetto and other things. Have you noticed any benefit to that?
They may provide some mild relief. There's some data behind saw palmetto, but really the data is from studies that are not well designed. It's not consistent. And then also, you got to be careful with these supplements that they're actually containing what's inside them. So they're not something I generally prescribe or recommend if a patient asks about them. I say there's conflicting data on things like saw palmetto, beta-sitosterol, pygium, zinc are ones that you might see in the prostate supplements. Really important to make sure you're buying it from a reputable source, make sure it's USP certified. And I think if your symptoms are getting to the point that you think you need to take a supplement, make sure you're talking to your doctor about it as well. Number one, it may interact with your other medications. And number two, maybe you need to see a urologist and talk about these symptoms more and make sure there's not something else going on.
Right. All good advice. For the people in their 20s and 30s, the younger folks right now, what kind of things can they be doing to be proactive about prevention of prostate disease?
The things that are good for overall health are going to be good for your prostate. Eat well, stay active, don't smoke, manage your stress. Sometimes if you have a lot of stress and tension, that can go down to the pelvic floor and cause some urinary dysfunction. If you have things like leakage, pelvic floor exercises can be helpful. There's been some studies that have also shown that being sexually active can reduce your risk of prostate disease. At least 2 studies have shown that more frequent ejaculation was associated with lower rate of prostate cancer. Not huge evidence out there, but maybe that's something.
Okay. Well, there you go. Have healthy relationships.
Healthy relationships.
Yeah. Good. I'm sure you have many stories, but can you think of any from the top of your head, a success story of a patient that you treated for prostate disease that was impacting his quality of life and how they've lived well with it since then?
Lots of success stories of gentlemen that were told, well, you have to get your prostate out or you have to get radiated. There's no other option. And we were able to treat them with one of these technologies or get them on a clinical trial. And here we are years later where, they have not had recurrence of their cancer. They've avoided invasive treatment, side effects, and they're very happy.
What do you think are the biggest barriers preventing men from seeking medical care, not just their prostate health, but just their health in general? Because I feel like, at least from my observation, sometimes it's too late. Or my father's a good example. He's 87. He refuses to go to the doctor.
I mean, maybe men feel like they're too busy or they, can't take off the time from work. Or we'll probably all see those patients where they'll say, well, I don't have any medical conditions, but I've also haven't been to a doctor in 30 years. So I think it's important to get checked out. From the prostate specifically in urology, men might be embarrassed or it's not something you typically talk about, over coffee with your friends. But I'm sure if they did, they'd realize a lot of men are having these same issues. It's a lot more common than they think.
Yeah, yeah. And to add to that, in my practice, I do see just a lot of days ruined when the whole bladder issue gets in the way. People plan their days around their bladder and they don't get sleep because of urgency and having to go so often. So early treatment from that aspect can help that improve quality of life there too.
One of the questions I'll ask patients is, what does this keep you from doing that you like to do?
Yeah.
And if they have an answer like that, then we got to do something. If it takes them a while to scratch their head, then maybe we're not at that point. If you always know where the next bathroom is, then it's probably time to have a conversation.
Right. Thank you for that.
Yeah.
I have one last question that we like to ask our guest speakers. What does aging forward mean to you, and how do you like to, age gracefully?
I think aging well is staying active physically, but also mentally, being proactive about health, living life fully at every stage, realizing it's going to be different at every stage. As you age, you're going to have more limitations. Things are probably going to ache more, but find things to do, and it doesn't have to limit you. The goal isn't just quantity of life, how many years you're going to live, but the quality and how you can make the most out of it.
Yeah. So. Thank you for that. I think, and that's what our listeners really enjoy, is that we're not just talking about a medical issue. We're talking to an expert about how they live their lives. And we're all in the same boat, right? We're all getting older, but there's so much we can do about it. And I didn't realize how much fun I'd have talking about prostate health today, but I really appreciate you being here. And I know this will be a very well-received message. So thank you.
Well, thanks for having me.
So that's all for this episode. Hopefully you're feeling a little bit more informed, inspired, and empowered. To learn more about Dr. Lomas' book, Mayo Clinic on Prostate Health, check out the show notes online. On the next episode of Aging Forward, we'll be talking about the value of preventive screening and healthy aging. What are the general outcomes for older adults who have gone through, say, better preventive health screening?
I definitely see lower rates of hospitalizations, less healthcare expenditure when it comes to money, and higher rates of cure depending on what we're dealing with. And the rule is usually when we catch cancer in patients that have their normal follow-ups, we usually catch it early, so it never gets that bad. And in fact, many times we can get patients in complete remission, meaning that we are able to cure them as long as we catch things on time.
If you have a topic suggestion for a future episode, you can leave us a voicemail at 507-538-6272, and we might even feature your voice on the show. For more Aging Forward episodes and resources, head to mayoclinic.org/agingforward. And if you found this show helpful, please subscribe and make sure to rate and review us on your podcast app. It really helps others find our show. Thanks for listening, and until next time, stay curious and stay active.
This podcast is for informational purposes only and should not be relied upon as medical or legal advice. Always consult with a qualified healthcare provider for any medical questions. The appearance of any guest does not imply an endorsement of them, their employer, or any entity they represent. The views and opinions are those of the speakers and do not necessarily reflect the views of Mayo Clinic. Reference to any product, service, or entity does not constitute an endorsement of or recommendation by Mayo Clinic.
If you're a podcast host, listen up, this one's for you. My name is Allie Jackson. I'm the host of Finding Mr. Height, a dating and relationship podcast that I've been doing for 4 years now, sharing my positive and practical approach to dating that's built on my own life experience. And I wanted to share another experience that I've had, my secret behind monetizing my show. It's called Red Circle, and I was just telling my colleague about how much I love their platform. With Red Circle, not only am I getting a seamless hosting experience, but I also love the support I receive in ad sales. It's not just typical ad sales either. It's targeted opportunities based on my show and my life. And the platform is super simple. You just set your preferences and Red Circle matches you with sponsors that align with your show. You can vet every opportunity and their platform gives you great analytics. More recently too, my Red Circle team has brought me opportunities outside of my podcast on social media to really augment the podcast partnerships, bring them full circle. I just can't recommend them enough. If you want to give it a try, go to redcircle.com to get your free trial. That's redcircle.com for a free trial.